Hello, 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 hello. Hi, everyone, and welcome to tonight's webinar on asthma management and device matters. I will be your moderator, Dr. Miles Monroe, CPD coordinator at the Pharmaceutical Society of Kenya. At this moment, maybe as we wait for more of our colleagues to join in, maybe respond in the chat where you're joining us from. Hi, Solomon. Nice to see you. Hi, Duncan. Hi, Cyprian. We are thrilled to have all of you join us from across the country. Yeah, if there's anyone from beyond Kenya, we'd love to see you. Once again, welcome to tonight's webinar. Good evening, esteemed colleagues. I am honored to serve you as your moderator for tonight. And hello from Void Joshua for tonight's session. Lydia from Migori, karibu sana. Hello, I am very curious. Who could be from Argentina? Sorry about that. Maybe just confirm my sound is okay. Sylvester. Hello, Rogers from Kisumu. Uwaya Chemist Butere. Cosmas Bomet. Sudi Indiani. Nairobi Shamba la Mawe. I don't know what neighborhood that is. Alex from TZ Boda. Karibu sana. Welcome everyone. Ida from Trans Nzoia and Washington from Malibu, Kisumu. Melvin from Eldoret. Yeah, finally I have someone from Argentina. Yes, and who is from England? Tonight we'll be diving into a crucial topic in respiratory care, that is asthma management and device matters. In asthma, prescribing the right molecule only serves as half of the battle, but ensuring that this patient can and actually does use the device correctly is where we get clinical success. We will explore onto why the device choice is a cornerstone of the effective therapeutic outcomes. We are pleasured to have two speakers from AstraZeneca, Doreen Chege and Karen Cherono. You'll be hearing from them tonight. And maybe just before we start, I see we are 1 minute to 5 minutes past the hour. Allow me to lay down some ground rules, which you probably already aware of. The webinar tonight will be recorded and will be made available to our YouTube channel, the Pharmaceutical Society of Kenya. You will be muted during the entire course of this session, and in case you have a question, please make use of the Q&A tab. And well, maybe if you see your friend and you want to say hi, use the chat section for general remarks and basic interaction. For you to get CPD points for this webinar, minimum attendance is 75%. If the webinar goes for 2 hours, we expect you to attend over 75% of that, and that will guarantee your access for CPD points. Karibu sana Devayani from Nairobi. This webinar has been made possible through partnership with AstraZeneca, whose commitment to improving respiratory patient care continues to drive impactful education like tonight's session. To take us through tonight, as I have mentioned, we are joined by two experts from AstraZeneca's respiratory portfolio. That is Karen Cherono and Doreen Chege. They will be sharing their insights on the nuances of device selection and patient education in asthma management. At this point, just so we are very keen on time, allow me to welcome Nick from AZ. Here they go by the word AZ. Hi, Nick. I hope you can hear me. Nicodemus Omwango, who will introduce his team from AstraZeneca, and we may proceed with the webinar. Karibu sana, Nick. Oh, wait, before Nick actually takes it up, I'd forgotten a crucial point. Just, I mean, take a moment, go to PPB, subscribe to the webinar. It's valid from 16th to 24th of July. This will enable us to share tokens with you on time. Take a moment, just ensure you are subscribed. Check again, go to the claim tabs token, the claim tab, and ensure you are actually subscribed. Yes. So, Nick, the mic is all yours. I leave it to you to introduce the team. Thank you.
Good evening, everyone. The Pharmaceutical Society of Kenya, Dr. Miles, for the wonderful introduction. So my name is Nico Mwango, and I serve as the sales manager for the AstraZeneca, as you have rightly put it, the AZ Pharmaceuticals portfolio at AstraZeneca. So we usually have two divisions in AstraZeneca. One handles oncology brands. You might have heard of our brands, the likes of Zoladex and Tagrisso, Casodex, and the likes. Then we also that handles the biopharmaceuticals unit. So in this one, we have Symbicort, which informs our topic for today. And then also we have the likes of Foxiga, Cresta, and Nexium, which I know most of you are basically cognizant of. So we work through our partners, that is the P World, and today before you, we have two speakers. The first speaker will be Karen Cherono. So Karen Cherono is a medical representative with AstraZeneca, also under the DP World partnership. So she has over 7 years of experience in respiratory care and also is experienced in implementation of gender-based asthma management discussions. And she's actively also involved in patient education initiatives on inhaler use. Slightly later, she'll be followed by Doreen Chege, who also has over 10 years experience in the pharmaceutical industry and respiratory care. She also focuses on guideline-directed asthma and COPD management in health therapies and patient adherence. She's also passionate about improving patient outcomes through effective use of inhaled therapies. So we have quite a pool of individuals who have been in this space for quite some time. And yes, we are here basically to offer education also on appropriate device use, because it's one of the gaps that is there in asthma management. As much as you might get the right medication, but if you don't get to appropriately use the device, it might have limited impact on the patient and even increase their severe exacerbations. So at this point, I'd like to welcome Karen Cherono to start us off with the first segment. Then we shall be followed by Doreen Chege. Then we'll have the Q&A session. So thank you so much and welcome, Karen Cherono.
Good evening. Thank you all for joining today's session. We are glad to have you here. We really appreciate your presence and the role that you play as pharmacists in asthma patient care. As mentioned, today's topic is on asthma management as well as the device aspect. I'll be taking you through the asthma management in terms of the therapeutic solution that we have in AstraZeneca, and my colleague later will handle the device use. So to start off this session, we usually say there is no debate when it comes to asthma management, that Symbicort is the guideline recommended therapy because it's been proven to reduce exacerbation both in asthma and COPD. And for today, as mentioned, the focus will be on asthma. Next slide, please. So for the longest period, salbutamols, or what we call the short-acting beta agonists, have been the mainstay when it comes to asthma management. It's been the commonly used inhaler over the past few years. However, as we all know, short-acting beta agonist SABAs do not treat inflammation and also do not protect against exacerbation. This applies both to patients who are using salbutamol alone, or even those who are using salbutamol together with a controller. Let's say, for example, a fixed daily dose of an inhaled corticosteroid. And symptoms are usually a sign of variable inflammation. At times, you may get a patient who is very compliant on their daily dose of inhaled corticosteroids, but in between, they still get symptoms necessitating them to use their SABAs. And this is basically because asthma is a variable disease with symptoms that are variable depending on the triggers that the patient has been exposed to out there. And despite the fact that this patient had taken their daily dose, they may still get extra inflammation in between during the day because of the triggers. And in that case, they will always have to reach out to their SABAs to get the relief they need. And the thing is, SABA, yes, will give them the quick relief that they are looking for. It will reduce the symptoms, but it will not address the underlying inflammation. As we can see from the graph here, there is this part which is showing the inflammation, like the variation in inflammation as well as the symptoms. So we see that the more this patient is getting inflammation, the more they are getting the symptoms. And because this is a fixed dose, this extra inflammation remains untackled. And if this happens over a repeated period of time, you find that actually it leads to a fully blown exacerbation. The way we see in the graph where we have a peak point, which is the highest, where we have very high inflammation. And in this case, the symptoms are very high, meaning actually it is representing a patient who is at a fully blown exacerbation. And the thing is, 1 in every 2 asthma patients at least has experienced an exacerbation in a given year. And as we all know, the more this patient is getting exacerbation, the more also it is affecting their lung function and their quality of life. So yes, inhaled corticosteroid maintenance will provide a steady level of protection, but that may not be enough because, as we have mentioned, asthma symptoms are not steady. They are always variable. There are days when the symptoms are more and other days the symptoms are less. So a steady approach for a variable disease actually is not usually sufficient, and that is why your patients may still be getting exacerbations despite using their regular ICS dose. Next slide, please. As we have mentioned, all patients using SABA, even with maintenance, are still at a risk of getting exacerbations. We had also mentioned that SABA had been widely used the past number of years before the changes in the GINA guidelines. And let's take a look at this study. This is just data from Sabina study, which was a global real-world study involving 1 million patients from over 40 countries. And Kenya was actually one of them. And it was found actually that 40% of patients frequently use their SABA. And in this case, we mean that they are using their SABAs at least 3 to 4 times a week, despite using their daily controllers, meaning that they are still getting symptoms in between, despite using their ICS-containing maintenance. And 32%, and they experience 32% more exacerbations and more hospitalizations and higher mortality risks. As I know most of you could already be knowing, according to the GINA guidelines, a patient who is using up to 12 SABA canisters per year, meaning at least one per month. This could be a patient who is even using, let's say, at least 3 to 4 times a week or slightly more. You find that such a patient is at a risk of death. And that's why we are saying that these patients who are using more SABAs, they are still at a higher mortality risks and hospitalizations. As we narrow down to Sabina Kenya study, it's found out that 61.5% of the patients experienced at least one severe exacerbation in the past 1 year. And here we are looking at a severe exacerbation, most probably even requiring hospitalization. And as we all know, exacerbations are usually emotionally significant for the patients. They really feel that their life is in danger and they really don't know where they are, whether they are even going to make it. So, 71.9% of patients were prescribed more than 3 SABA canisters. And as we all know, according to the GINA guidelines, a patient who is even using 3 or more SABA canisters in a year, they are at a risk of getting an exacerbation. And 34.8% of these patients were prescribed at least 10 SABA canisters. That's quite a big number. And 38.8% of patients purchased SABA over the counter. 66.2% of patients purchased even more than 3 SABA canisters over the counter. So we still see that the use of SABA is still rampant in our country. And that is why we still find that patients are still getting a lot of exacerbations and even mortality, despite the fact that we have wonderful solutions, even from AstraZeneca within the country, that can benefit these patients. Having looked at the general picture of SABA use in Kenya, what does the GINA guidelines tell us about SABA? Let's check this in the next slide. So this is an excerpt from the GINA guidelines, treatment strategy 2025. In 2022 and 2023, the GINA guidelines updated its recommendation that for adults and adolescents, they should not use SABA alone without concomitant inhaled corticosteroid. However, as we all know, at times it's really hard to control patient behavior, because for most patients, actually, when they have 2 inhalers with them, they rarely adhere to the inhaled corticosteroid, and in most cases, just reach out to the SABAs now when they start getting the symptoms. So in 2025, the GINA guidelines actually further narrowed down to separating the tracks in asthma management to track 1 and track 2. So track 1 is the preferred track. And when we look at it, the GINA guidelines recommend that inhaled corticosteroid and formoterol should be is the preferred both controller and reliever. It can be used for both control and relief. And that when this is used together, like as a controller and a reliever, it reduces the risk of these patients getting exacerbations compared to a patient who is on step 2. And in this case, a patient who is using a controller, a fixed dose controller, or an ICS LABA, and then plus a SABA PRN. So that is why you find that step 1 is the preferred step, because the patient will be having 1 inhaler with them. So we see that in this case, SABA is no longer the preferred one, because even when we look at step 2, where for these patients now who are using, let's say, a plain inhaled corticosteroid plus a combination ICS LABA, they are still recommended to use a reliever that has an inhaled corticosteroid. So you find that the reliever is as needed ICS SABA or as needed SABA. So you find that really the GINA guidelines is no longer recommending salbutamol. And this is basically because we know short-acting beta agonists will give the patient the required relief without tackling the underlying inflammation. We can check the next slide. So having looked at what the GINA guidelines is recommending, we have a solution in AstraZeneca that is actually giving your patients an opportunity to have a controller and a reliever in one device. And that is ICS formoterol, which had been recommended clearly by the GINA guidelines as under the preferred track, which is track 1. And why is Symbicort? Because Symbicort has both a reliever and a controller. It's a 2-in-1. Formoterol works as fast as salbutamol to relieve the symptoms of your patients within 1 to 3 minutes. And the beauty is that because it's a long-acting beta agonist, the duration of action will actually cover your patient for up to 12 hours. So it's a longer duration as compared to the short-acting beta agonist. And one thing to note that we need to note here is that the GINA guidelines really specified that it is ICS formoterol, not even ICS LABA, because as we know, formoterol is the only LABA with a fast onset of action, unlike the other LABAs like salmeterol, which will act later. So that is why formoterol is the formoterol-based inhaler is what can be used for both relief and control. And in this case, we have it here with Symbicort. And then Symbicort also has a controller which treats the underlying inflammation with every inhalation. And also, the inhaled corticosteroid in Symbicort, which is budesonide, rapidly dissolves in the mucus layer of the airways within 6 minutes, which is not like the other inhaled corticosteroids available. For example, fluticasone, which takes about 5 hours, or beclomethasone. So you see, we really have the best here, fast onset of action in both relieving the patient and also tackling the airway inflammation. And this diagram here clearly illustrates the difference between a patient who is using Symbicort, the airway of a patient who is using Symbicort, and a patient who is using SABA. When we look at the two, you find that, yes, the patient who is using SABA, the airway smooth muscles are relaxed, just the way, yes, the Symbicort patient smooth muscles are relaxed. However, one thing is that salbutamol or short-acting beta agonist doesn't treat the airway inflammation. So when we look at the first diagram of this patient using salbutamol or short-acting beta agonist, the lumen is narrower, meaning the inflammation is still there, unlike the patient who is on Symbicort, where the inflammation has been dealt with, and then the smooth muscles are relaxed, almost just looking like a normal airway. We move to the next slide. Just to reinforce what I have mentioned in the previous slide, that Symbicort works as fast as SABA. And this is data from one of the studies, Saberova et al., where we see that the onset of action of formoterol when compared to salbutamol, it is within 1 to 3 minutes, which means that it is working works as fast as SABA to give your patient the desired quick symptom relief that they usually look for in salbutamol. We move to the next slide. Having discussed about the GINA guidelines, inflammation, and also Symbicort that we have in AstraZeneca, I'd like us to take a look at a patient profile that we have here. So this patient is patient Mike, and Mike is a non-smoker and has an exacerbation history. He was prescribed medium dose ICS LABA plus SABA. He is using his ICS LABA SABA as recommended every day. He is very compliant, but is still reaching out for SABA frequently because he feels symptomatic. Mike is at an increased risk of exacerbation, hospitalization, and mortality. When we look at this patient, Mike, it's a picture that reflects most of the asthma patients that we get in our hospitals or even in pharmacies when they are coming to refill their medication. And this is a patient who we wouldn't expect to be getting symptoms here and there because one, he's compliant in their medication. So he should be getting optimally controlled. And even he has even implemented what I can call lifestyle modification or non-therapeutic factors, like he's a non-smoker. So he's not triggering these like attacks, but still he gets symptoms necessitating him to reach out for his salbutamol. Now, if you're in this situation, what would you do for this patient to help him? Would you step up his treatment or change the reliever? And the best option is actually to put Mike on Symbicort because as I had explained previously, asthma is a variable disease. So yes, despite the fact that patient Mike is very compliant in the treatment, still, in between, he gets inflammation because of exposure to triggers, necessitating him to use a reliever. And this inflammation buildup is actually what puts him at a risk of getting a fully blown exacerbation, hospitalization, and mortality. However, if Mike is put on Symbicort, as I mentioned, Symbicort has budesonide, and it will be handling this extra inflammation as it happens, and there is no carry forward that can build up and lead to a fully blown exacerbation. And why put Mike on Symbicort? Because Symbicort will work as fast as Saba, so the instant relief they were still getting from salbutamol, they'll still be able please go back, please. They'll still be able to get it with Symbicort, the first onset of action, which is 1 to 3 minutes. They'll still be able to get that. But on top of that, they'll now be able to get superior efficacy in terms of reduction in the risks of getting exacerbation. This data that we have here is from one of the studies, Kuna et al., where it is showing that patients who are using Symbicort for both control and relief, they had a 39% reduction in the rate of severe exacerbation versus higher dose ICS LABA plus SABA as needed. So you find that, yes, this is a patient who is using low dose ICS formoterol Symbicort, but still, because they are using it for both control and relief, what we call it smart therapy, they are able to get that prevention, 39% reduction in the risks of getting an exacerbation. And because this is a low-dose inhaled corticosteroid, they are still able to get a 25% reduction in the lower mean daily dose of inhaled corticosteroid versus a higher dose ICS LABA plus SABA as needed. This is just to explain that when we were looking at patient Micah, because he's not responding to the current treatment, if you put them on, let's say, a higher dose of ICS LABA plus SABA, what happens to the days when maybe the inflammation is not there, the symptoms are few? This patient is on a fixed dose. Whether the symptoms are there or not, they are using the higher dose. However, this Symbicort patient, they are using daily a low dose, and they only top up the dose when seeking relief, meaning they are topping up the daily inhaled corticosteroid requirement as needed. When the inflammation is more, they get more inhaled corticosteroid when they are seeking relief, which is able to tackle inflammation and prevent exacerbation. When the inflammation is less, they just remain with the daily low-dose inhaled corticosteroid. That's why you find that as much as there is the superiority in reducing exacerbation, the total mean daily dose will be lower as compared to this patient who is using high-dose ICS LABA plus SABA. And that is the more reason why we need to put patient Mike on Symbicort, and also any other patients who come to you that they are not well controlled and they are still using two separate inhalers like ICS plus SABA or ICS LABA plus SABA. That is the opportunity to ensure they are on Symbicort Smart, that is as reliever and controller. We move to the next slide. So basically, this slide is just illustrating what we were talking about, patient Mike's situation, that the symptoms are variable, and that is why he's still at a risk of getting an exacerbation. And that is the reason why they should be able to be put on Symbicort to prevent them from getting these peaks of inflammation, which can lead to an exacerbation. Next slide, please. Yeah, so in summary, with Symbicort Smart, that is Symbicort for both maintenance and reliever, these patients can be able to get fast symptom relief because Symbicort works as fast as SABA. It is superior in reducing exacerbation, and it's only one inhaler that keeps life simple for that patient, because a patient is more likely to comply when they have one inhaler they have to use, unlike when they have two. And also, Symbicort makes use of that natural relief-seeking tendency of patients, because patients at times they don't even take their inhalers every day, but tend to remember when symptoms start coming. So whenever now they are using their inhaler more, at least they are not using just a bronchodilator, but they are using Symbicort, which has an inhaled corticosteroid, which is able to tackle these inflammations that have come, and the patient is able to live a better quality of life and to get that protection from exacerbations and from hospitalizations or even mortality. So that is all from me. Having talked about the disease and what we have, the solution we have in AstraZeneca, the next step will be on the device, and I'll let my colleague Doreen to continue with Symbicort device. Thank you.
So thank you, Karen, for that introduction into asthma. So I will take you through the next session, which is the device technique, and a bit about our Tabuhaler. So as you're aware, according to the GINA guidelines, the primary goals of asthma management are, number one, to achieve good symptom control. And the second goal is to minimize the risk of future complications. So what we are saying is that these goals are achieved through appropriate medication, follow-up, which includes a personalized asthma action plan, and finally, a correct inhaler technique. You agree with me that without the correct inhaler technique, despite having a good inhaler, the patient will not be able to achieve the asthma control and finally minimize the risk of future complications. So we got right into our Tabuhaler. It's easy to use, and we'll show that with the subsequent slides. It requires no coordination of inspiration and actuation at the same time. The second point is that it contains a dose counter, which indicates remaining doses, and this supports adherence as patients are able to track the inhalations which they are taking. So for Symbicort Tabuhaler, typically what is commonly used, the Symbicort 164.5, 120 micrograms. You'll find that once you start using it, the calibration will move after every 20 inhalations and not one inhalation at a go, okay? It's a dry powder inhaler, so there's no shaking that is required with the Symbicort Tabuhaler. And finally, it's effective and reproducible dosing with high lung deposition, even at very low flow rates. So we said that Symbicort is a dry powder inhaler, and the Tabuhaler is designed for optimal lung deposition. So you will find that the lung deposition via the Tabuhaler was 3 times higher than the PMDI. This is because Symbicort contained optimally sized particles, and the requirement is 1 to 5 micrograms for better lung deposition because of the size of the airways. The optimally sized particle proportion, were 2 times higher with a Tabuhaler compared to a DPI. The variation of dosing in PMDI users were 2 times higher compared to the Tabuhaler users. And finally, the lung deposition via Tabuhaler were 2 times higher versus select DPIs. So this is what makes the Symbicort Tabuhaler very optimal for lung deposition. So Symbicort Tabuhaler is effective across all ages and severity, and we will show you that as we move along. For asthma maintenance, for acute asthma, for severe COPD, and children from 6 years with asthma. So patients require a peak inspiratory flow of 30 liters per minute to obtain a good clinical effect. So just for practicality purposes, 30 liters per minute, what do we mean by 30 liters per minute? This means it was compared to drinking from a straw. So when you're drinking from a straw, for example, you're taking a soda or juice, you only need such an inspiratory flow of 30 liters per minute. So patients don't require a lot of energy to lift the dose from the Tabuhaler. Okay. So for the Tabuhaler effectiveness, I'm going to show you how this measures across ages and severities. So patients of most ages and severity of asthma and COPD have been shown to be able to generate sufficient inspiratory flow of 30 liters per minute, as discussed in the previous slide. So for patients who have COPD, you'll agree with me that they have very low lung function. And on average, they generate an inspiratory flow of 53 liters per minute. Remember, we said that for the Symbicort Tabuhaler, a patient will only require 30 liters per minute. So for COPD patients, they can comfortably be able to lift the dose from the Tabuhaler because we've seen that they are able to generate 53 liters per minute. Children with asthma, so we have the 80/4.5 micrograms Tabuhaler, which is recommended for children between 6 to 11 years. So for these children, as you can see, 3 to 6 years normally generate an inspiratory flow of 60 liters per minute, while the 7 to 10-year-olds generate an average of 70 liters per minute. So with all this age group, these children can comfortably be able to lift the dose from the Symbicort Tabuhaler. And finally, the patients who present with an acute asthma. These patients generate an average of 60 liters per minute through the Tabuhaler. Only 2 of the 99 patients generated below 30 liters per minute. So what we are saying is that it will still be, the 26 liters per minute will still be adequate for this group of patients with acute asthma. And finally, patients with asthma are able to generate at least 40 liters per minute. So what we are saying in this slide is that patients across these ages and severities, be it COPD, be it children from 6 years, be it patients who present with acute asthma and just patients with asthma, they all can comfortably be able to use the Symbicort, and that is to lift the dose from the inhaler. So these are some of the features of the Symbicort Tabuhaler. So the Symbicort Tabuhaler delivers particles between 1 to 5 micrometers, for optimal lung deposition. So what this means for your patient is that having this size of microparticles means that the drug is able to penetrate to the airways, and therefore it gives the patient relief, okay? Secondly, Symbicort Tabuhaler has one of the highest lung deposition, that is 32 to 44% compared to any other device. So any other device, when we are comparing, say, pressurized metered dose inhalers, pressurized metered dose inhalers are able to deliver only 15%. So what you're saying, when it comes to your patients are well controlled when they're using Symbicort Tabuhaler, because most of the drug is deposited in the lungs where it is required. Symbicort Tabuhaler is unaffected by storage and environmental conditions. We know that most of the inhalers that are locally available, most of them will actually be affected either by very dry or humid environment or very cold environment. What you're saying for Symbicort, it is not affected by any environmental or storage conditions. So whether you're going to the top of Mount Kenya or you're going to the northeastern region, consistency of the drug will still remain the same. Finally, an inspiratory flow of 30 liters per minute is only required for the Symbicort Tabuhaler, as I've explained in the previous slide. So what this means for the patient is that any kind of patient, we've covered all the patients who you come across, be it COPD, be it patients with acute asthma or just asthmatic patients. So we say keep life simple with an easy-to-use inhaler. So these are the 3 steps which we will show you as we go along. So we say twist, click, and inhale. Those are the only 3 steps required to use the Tabuhaler. 96% in a multi-center of patients found that the Tabuhaler was convenient and easy to use. So the significance of one. So for the Symbicort, as my colleague had mentioned earlier, you've seen from the GINA guidelines that now there's the recommendation for use of formoterol and budesonide. So a patient will only require 1 inhaler, which is recommended as 1 to 2 puffs daily, and additional inhalations, which we say is PRN, with 120 doses per canister. What are we saying? Is that with Symbicort, the patient the normal maintenance dose of 1 to 2 inhalation, once or twice daily. Other than that, in the event that the patient is exposed to their triggers, they can still reach out to the same Symbicort and take additional inhalations for symptom control. Secondly, 1 device for reliever and maintenance. As I've explained, you'll get fast relief of symptoms as needed compared to using SABA alone. Therefore, managing worsening of symptoms and protection from exacerbation. When it comes to the steps, is 1 twist, 1 click, and inhale. Easy to use device that simplifies the life of your patients, and therefore also improving compliance. So these are the SKUs that are locally available in the local market. So we have the Symbicort 160/4.5 micrograms, and it comes as 120 doses. We also have Symbicort 320/9, 320 being the budesonide and the 9 being the formoterol. So we have these 2 locally available in Kenya, that is. So when it comes to the Symbicort Tabuhela, we have we gathered some frequently asked questions, and I'm sure most of you will also have these questions or have been having these questions. So we are going to address some of them. So the first question is, can more than one dose be administered at a time? So the answer will be no. The Tabuhela is designed to dispense only one dose at a time. If the user twists the grip more than two turns, it will only deliver one dose and not two. Will I be able to taste the drug? This is a common question, especially if you find a patient is being maybe switched from maybe a pressurized meter-dose inhaler, that is the sprays, which are very common, and now they are being switched to Symbicort. Remember I said Symbicort has optimally sized particles. This allows maximum deposition in the lungs, so it has very fine powder. So patients are not able to taste the drug. And what this means, or what this translates to, is that the drug actually settles at the site of action where it's required, unlike most of those inhalers where most of it either deposits itself around the throat. Therefore, incidences of oral thrush will be experienced with any other kind of inhalers. So the dose and amount of powder delivered by the Tabuhela is very small. Therefore, most patients do not feel or taste the medicine. So Symbicort has a click sound. So why do I hear a click sound? A click is heard when the dispensed dose is ready for delivery. This is a feedback feature to aid the patient handling. It doesn't matter whether the click comes on the first or the second twist. Once they hear the click, that's what we say, regardless of which side they twist the grip, it's a confirmation that a dose has been loaded and it's ready for use. What is the sound I hear when shaking the Tabuhela? So when the Tabuhela is shaken, especially after it's over, you will hear a rattling sound that is made by the desiccant. The desiccant is used to protect the medication from moisture. So as you're dispensing the Symbicort Tabuhela to your patients, please advise them that once the dose counter gets to 0, that actually it's at 0. There is no more drug in the Tabuhela. So what this means is even if they shake, they will still hear some rattling sound. So that rattling sound was just the desiccant and not the drug. When the dose counter is at 0, it actually means the drug is over. Okay. So how do I clean the device? Clean the outside of the mouthpiece once a week with a dry or soft paper tissue. Do not use water and do not remove the mouthpiece from the Symbicort Tabuhela or attempt to twist the mouthpiece. Should I rinse my mouth after taking a dose? Candida infections in the mouth cavity may occur when using inhaled steroids, such as Symbicort. To avoid this, users should rinse their mouth with water following each dose. So what this means is that despite having very small particle size, you know that this is a common side effect with all steroids. So that's why we are saying that you should rinse the mouth. However, in Symbicort, the side effects are minimal compared to other like pressurized meter dose inhalers. Okay. So we are coming to almost the tail end of the presentation. So this is one of our initiatives. AstraZeneca, in the year 2021, AstraZeneca launched an initiative that is called the Africa Pumua Initiative. So this initiative consists of 2 pillars. The first pillar is improving asthma care in Africa. And the second pillar is ensuring asthma medication is not only accessible, but also affordable to the patients. You will agree with me that one of the barriers to asthma care is normally the cost. Therefore, AstraZeneca has partnered with stakeholders like MEDS and KEMSA under the Access Program, and now county, sub-county, hospitals, and faith-based organizations can access Symbicort at a cost of 1,000 shillings. So when you place an order for the Symbicort 160/4.5, which is 1,000 shillings, this is able to last your patients for at least 2 months. So with this one inhaler, remember you can use it both as reliever and maintenance, compared to the traditional approach, which had the use of inhaled corticosteroid separately and SABA separately, which would ideally increase the cost and lower compliance. So with Symbicort, what we are saying is that with that one canister, at that cost, the patient is able to have it for 2 months, still use it as reliever and maintenance, and also adhere to their asthma plan, therefore increased or improved compliance. So under the Pumua initiative still, AstraZeneca created this interactive patient website, which is called Yes to Pumua. So if you go to either Google Chrome or Safari, and you just type Yes to Pumua, just what is appearing in the screen, if you type that, you will see a very interactive page. So it talks about asthma, it defines what asthma is, what medication the patient has, why, what short-acting bronchodilator means, what an inhaled corticosteroid means, all that, anything asthma. So we normally advise you that even as much as you go through it, you can also share with your patients so that they better understand asthma and the treatment guidelines as well. So please go to Google Chrome and type Yes to Pumua, and you will see a page which is very, very interactive. So this is another initiative from AstraZeneca. So we've gone a step further as we move towards the digital world. So other than, sometimes you will show or teach a patient how to use the Turbuhaler. Then once they go home, they forget the steps. So if you scan this barcode right now, it will take you to a link. So the link will play a video, which I'll also play from my end, and you're able to see the steps towards how to use the Symbicort Turbuhaler. Okay. So I will play the video. So once you scan the barcode, it will take you to a link. And then once you play the link, then this is what you'll see coming up in your screen.
Welcome to the quick guide of your new Symbicort Turbuhaler. The journey to symptom control and maintenance begins with a visit to your physician. Using your new Turbuhaler. Turbuhaler has been designed specifically for the optimal delivery of inhalation therapies to the lungs. Every time you need to take an inhalation, it's a simple 2-step process after unscrewing the cover. Unscrew the cover and lift it off. Hold your Symbicort Turbuhaler upright with the red grip at the bottom. Step 1. Twist and twist back. To load the dose, twist the red grip as far as it will go in one direction, and then twist it back as far as it will go in the other direction until you hear a click. If it's the first time you use your new Turbuhaler, repeat the previous step again, twisting the red grip twice in both directions. Your Symbicort Turbuhaler is now ready to use. Hold your Symbicort Turbuhaler away from your mouth. Breathe out gently. Do not breathe out through your Turbuhaler. Step 2. Breathe in. Place the Turbuhaler mouthpiece gently between your teeth. Close your lips. Breathe in as deeply and hard as you can through your mouth. Do not chew or bite on the mouthpiece. The Turbuhaler delivers both the anti-inflammatory agent and the rapid-acting and long-lasting bronchodilator. As you inhale, air is drawn through the dosing disc and delivers the dose. Thanks to the vortex generated in the spiral channels of the Turbuhaler mouthpiece, the drug is efficiently separated into small particles. When inhaling through the device, it releases tiny particles of the medicine at just the right size for the parts of the lung where they are needed. Remove the inhaler from your mouth and breathe out gently. Repeat steps 1 and 2 if a second dose is needed. You may not be able to taste any medicine after inhalation due to the small amount of medicine inhaled per dose. After your daily doses, first replace the cover and then rinse your mouth with water and spit it out. Also, wipe the outside of the mouthpiece once a week with a dry tissue. Do not use water or liquid. You should also know that the dose indicator tells you how many doses are left. It is marked in intervals of 10 doses for the 60 and 120 doses inhalers, and in intervals of 15 doses for the 30 doses inhaler. Therefore, the dose indicator does not show every dose. You will be able to see a red mark on the window when approximately 20 doses are left. If you load your Turbuhaler more than once, the indicator will register it, but you will only receive 1 dose when inhaling. The grip still twists and clicks when the device is empty, and the sound you hear when it's shaked is produced by a drying agent, not by the medicine. Now you are ready to use your inhaler. If you have any further questions on the use of this product, please inspect carefully the instructions from the patient information leaflet found in the package, or ask your physician or pharmacist.
So that marks the end of the presentation. So we'll go now to the practicality of using the Symbicort Turbuhaler. So this is a dummy. The Symbicort inhaler is not transparent, but for purposes of demonstration, we have it as being transparent. So you unscrew the cap, okay? So we have the mouthpiece up here, and we have the red part, which is the rotating base. So this is what loads the dose, okay? We also have a dose counter. I don't know if it's visible, yeah? We have the dose counter. So the Symbicort 164.5, which is what is commonly available, comes in 120 doses. So, and just the same way the video showed, it will only move in 20 doses. So after every 20 doses, that's when you'll see a movement in the dose counter. When there are 20 doses left, you'll start seeing a red window, okay? There's that red window there. So this is just to prepare the patient either to go for a refill or to go back to the doctor to prescribe or to do a refill prescription. So I will take you through the steps of how to use the Turbuhaler. So they are easy. It's just 3 steps. We say twist, click, inhale, twist, twist, then back, you hear the click. So twist to the farthest end until you feel it's at the end, then bring it back. You hear a click. So the click is a confirmation that the dose has been loaded. So for the steps of inhaling the Symbicort, remember it's breath actuated. And this is the advantage Symbicort has over other locally available inhalers. It is breath actuated. What that means is that the patient will only get the drug once they inhale it, okay? So this makes it very comfortable, and it complements the natural seeking behavior of the patient. So if the Tabuhaler is new, we request that you, if you can, you prime it for the patient. So you first hear the first click if it's new, so you have primed the Tabuhaler. So now to load a dose, twist to the farthest end, then back until you hear a click. So the click, as I've said, is a confirmation that the dose has been loaded. So we go to how to inhale the Symbicort. So the first step is you advise the patient to exhale away from the mouthpiece because it is a dry powder inhaler. So they exhale out, then they will bring it to the mouth, seal the mouthpiece, put it between their teeth, not to bite, but gently, then inhale, hold their breath as much as they can, remove the mouth, the Tabuhaler from the mouth, then exhale away from the device. So I will do that now practically without, of course, talking. So we twist to the farthest end, bring it back. The dose has been loaded, so exhale. If a second dose is needed, twist to the farthest end, back until you hear the click, exhale out. So once you're done, you take the cup, you close it. Remember we said after every usage of the Symbicort, remember to advise the patient to rinse their mouth. So they will rinse and spit, not swallow. They spit out. So you keep the Symbicort if maybe it's one inhalation BD, then the next time they will repeat the same steps. Remove the cap, twist to the farthest end while it's upright, twist it back until they hear the click, then repeat the steps, okay? So some of the common questions which we experience is, of course, one we addressed during the frequently asked questions is the patient will not be able to taste the drug. This is because it contains very fine particles. This is to ensure that the drug is deposited at the site of action where it's required. Okay, so this is one of the commonly asked questions which we come across. The second one is for these patients, we have something also called a dark cloth test. So you will repeat the steps, twist, click. So if the patient has a dark cloth or a handkerchief or a scarf, they place it over the mouthpiece, then they inhale. Once they've inhaled, after they remove the dark cloth or the handkerchief or the scarf, they will see white particles on the reverse side of the scarf or the dark cloth. This is just a confirmation that the drug is actually there and that they are actually inhaling the Symbicort or the drug. So we have Symbicort available as 160, 4.5, available other than the retail pharmacies. We have the access program where patients can where hospitals can purchase from either meds or KEMSA. It's retailing at 1,000 shillings. So please get some Symbicort for quality asthma care and accessibility to your asthmatic patients. We've had very good interactions and feedback, especially from the county facilities, and we are also doing a lot of sensitization and education as well on the Symbicort as well. So this marks the end of my presentation. I will hand it over back to the host, and then we'll take the questions. Thank you for your time and for listening.
Thank you, Doreen, for the wonderful presentation. I don't know if you have anything else to add. I see we have so many claps coming in through the chat, and there's a request to reshare the QR code. I don't know whether you're in a position to reshare for now before we get into the Q&A.
Yes, I can reshare. So
Meanwhile, as you're resharing, I see we have a few questions. I'm gonna take, dear esteemed colleagues, the QR code has been shared with you. And maybe at this point, to either Doreen or Karen, there's a question on, is there an indication for hydrocortisone injection in COPD patients? This anonymous attendee feels like they're out of pocket. I don't know whether you're in a position to respond to that. Doreen.
hi, Dr. Miles, please come again with a question.
The question is there an indication for hydrocortisone injection in COPD patients?
So when it comes to management of COPD, I think we leave it at the discretion of especially the doctors, depending on how a patient presents at the clinic.
Okay. Thank you for that. There's a request to have the Swahili version of the Tabohela technique video. Maybe the team at AZ can work on that. And Dr. Joseph Nyaga asks for the two puffs, what is the separation time? Maybe we could clarify on that also.
So for the two puffs, immediately, remember I said for every click that's a dose that has been loaded. So there is not really like a waiting time before you can take the subsequent inhalation. So you can take it immediately.
Okay. Thank you for your response. And I see Chris has shared the link to the video. Thank you so much, Chris. On to one of our last questions. Is a spacer needed to aid inhalation from one of our attendees, Doreen?
So Symbicort cannot be used with a spacer. And to answer or to emphasize more, remember one of the slides which we discussed is that Symbicort can be used across different severities of both asthma and COPD. This is because the patient will only require an inspiratory flow of 30 liters per minute, which was compared to drinking from a straw. So basically, even patients who have an inspiratory flow, of course, of not less than 30 liters per minute will be able to lift the dose from the Tabuhaler. And that's why with the Tabuhaler, there is no requirement to use with a spacer. Thank you.
Okay. Thank you so much, Doreen. Siad says that is very informative. We have a few words of applause from Gladys and Simon, and Johanna also agrees that the information was very informative. As we bring this evening sessions to a close, I wish to just I don't have a lot of announcements, just one announcement to the attendees. And maybe as we're doing this, I'd like to remind everyone that please go on to PPB portal, ensure you're subscribed to the event Asthma Management Device Matters. Your keyword is asthma. Ensure you are subscribed as shown on the screen. And maybe Nick, I can let you prepare your closing remarks, but allow me to mention this. We have an ongoing FP training opportunity for community pharmacists. We are calling on all community pharmacists in the following 11 counties: Uasin Gishu, Nairobi, Kajiado, Kiambu, Nakuru, Meru, Kericho, Kisii, Kisumu, Machakos, and Mombasa to join this MOH approved FP training so that you can become a certified provider of essential FP services. The criteria is well set out in the form. For inquiries, kindly reach out to projects@psk.or.ke. This is a strategic opportunity for you to elevate your pharmacy practice, improve access to reproductive health services, and position your pharmacy as a leader in community health. I would like to invite Nicodemus, maybe on behalf of the AstraZeneca team, for a few closing remarks before we end tonight's session. Thank you.
Thank you, Dr. Miles. This is Martin. I'll take it on behalf of Nick. So good evening, everyone. Good evening, everyone. My name is Martin Mugira. I am the brand manager for the biopharmaceuticals unit at AstraZeneca. Now, first of all, let me start by once again thanking PSK for giving us this privilege to, talk to you during this session. And Dr. Miles, thank you very much for moderating the session and also for giving us this platform. Allow me to also thank my colleagues, Karen and Doreen, who have taken us through a very informative session around respiratory care, focusing on asthma and, drilling it to Symbicort and how Symbicort is different. I think during Karen's presentation, and I'll take just 1 minute because I know we are way out of time. You remember during Karen's presentation, she did show you a bit of results or, results that were shared from the Sabina study that actually showed that a lot of patients are still buying Sabas over the counter. For you as pharmacists, we really count on you to help change this narrative. Now, I would also like to acknowledge Nick, who is the team lead, who helped to put all the team together and put all this together. And finally, to all of you as pharmacists, more than 1,900 who were able to attend this session. You showed up for your professional growth. We really appreciate you finding time to attend this session. We definitely know that a lot of patients' first point of care is at the pharmacy. And again, we count on you because good inhaler counseling really changes outcomes. And I think that this came out very clearly from both Doreen's and Karen's presentation. From AstraZeneca, the commitment that we want to give you is that tonight is just part of a longer partnership. You saw us during the conference. For those who are in the conference a few weeks back, we commit that we will continue supporting both in education through such platforms, but we will also continue supporting patients in terms of access. And I think my colleagues did not mention that Symbicort is actually, I think Doreen didn't mention that we have this product in Meds and also in KEMSA. I know probably for those who are working in the government hospitals, if you have requested for it, you may not have found it in KEMSA the last couple of months, but we are working hard. We expect that it will be in KEMSA in the next few weeks. So yes, support in terms of education and also in terms of patient access. So thank you very much for attending today and listening to us. Thank you, Miles. Thank you, Karen, Doreen, Nick, and all the attendees for this evening. Good evening to all of you.
All right. Thank you so much, Martin. Thank you to our speakers, Doreen and Karen. Thank you, Nick. I want to express our sincere appreciation to AstraZeneca for collaborating with the Pharmaceutical Society of Kenya to bring this vital CPD session to life. And finally, to our OGs, the esteemed members and colleagues who have actively participated in the questions and also in the chat also. Thank you, Celestine, for the kind words. Thank you, Simon, Grace, Sema. I don't know how to pronounce it. Sema Shah. Or is it Sima Shah? Before we log off for tonight, just a reminder to make sure you are subscribed on the PPB portal. And as we head back to our community pharmacy practice, remember the device truly matters, and we have learned about Symbicort. So thank you once again for joining us tonight. And to all of us, have a wonderful evening. Stay safe and good night.